A meeting of our NIEHS Center and our Center Seminar Series. I'll introduce our guest in just a moment, but first I want to thank you all for attending and remind you that there is at least one more seminar in the series for the academic year, which typically runs for us in the seminar series from September to June. Next month on the first Friday, which would be June 4th, we will be welcoming Bert Brunekrief from Utrecht in the Netherlands, who will actually serve double duty. He will be speaking to us as our NIEHS seminar speaker, but also as our John Peters Lecture presenter on behalf of our mentor and the person who founded the Environmental Health Division here at USC and led our center, actually our NIEHS center, for many years. John Peters really trained several of us and provided us an opportunity to sort of work together, learn together, and grow. And now we have a much more diverse and complementary and lucrative operation in terms of many research projects by virtue of John's vision. And so we celebrate that. We'll celebrate that with Bert Brunekrief. Today we're celebrating with Gwen Coleman, who is the acting director of NIEHS. We've known Gwen, many of us have known Gwen for quite a while, had the fortunate opportunity to work with her on a number of different things. She, of course, directs, for over a decade, she's directed the extramural research program at NIEHS. She's been involved and oversees the Superfund program, the worker education and training program, and I think she's probably got her finger on the pulse of most everything that's going on at NIEHS. And much to the good for everybody. One of us, she was trained as an environmental epidemiologist and has spent most, if not all, of her career at NIEHS. And so today she will be speaking to us about her reimaginings, her visions for what things are happening. And so without further ado, I will happy to welcome Dr. Gwen Coleman.
Hi, everyone. Thank you, Ed, for those kind words. And also thanks for reminding us about John Peters' legacy. I came to USC for the first time. At first, I was coming as a program officer for a review for the core centers. And then I was invited back after that by John and got the opportunity to spend time with some new investigators at USC. And I really always enjoyed having the opportunity to brainstorm and learn from the team and all the work that was going on at USC. So it's really a pleasure to be back. I wish I was there in person with you all. I love coming to Los Angeles and to visiting the USC campus, but we'll do the best we can. This morning's meetings have been very exciting and inspiring. It's been great to talk with everyone. So I'm not going to reimagine my vision for anything. I'm really going to introduce some concepts that I think we all are aware of, but I want to think about them with you in a new way, because I think, as always, we want to continue to evolve the field of environmental health research. And what presents at this moment is really the opportunity to rethink how we do prevention research, how we think about intervention, and how we move forward with the rest of the fields of public health to make sure that the populations that we work with and care about most aren't left behind as we're thinking of public health interventions. Next slide, please. So, this is a common framework for all of us here at the lecture today. We often think about exposure disparities or environmental exposures, and everyone, I'm sure, at this lecture has understands the concepts of environmental justice and has worked with many communities as part of the work of the USC Center and research across the USC campus, and with your partners at UCLA, as you used to be a group that worked together on these things and probably still have many ties. And put it in the context that, environmental exposures and environmental disparities don't happen alone. Right? They're in their silos sometimes, but they're in context. They're just one of many of social vulnerabilities that occur in the populations that we work with and care about. And then, of course, we all know that there's a variety of biological susceptibilities that individuals and populations have. And these things occur across the lifespan, pre-birth, pre-pregnancy, during pregnancy, birth, all the way through the frail elderly period. And NIEHS over the years has tried to focus on sort of understanding the framework for these windows of exposure and windows of susceptibility, but also creating exposure metrics and opportunities to explore them over the lifespan. So I would like to think about these things as not separate, like funnels into this. I'd like to think about them as like almost 100% overlapping, right? One does not occur without the other occurring, and you only have to walk through any neighborhood that's impacted by environmental exposures to a significant degree to understand that these things are impacting the population simultaneously, every minute of their day. Next slide, please. Next slide. Oh, here we go. Whoop, no, what back one? Sorry. So, in this year's context has shine a new light on the work that we've all been doing with environmental justice communities. We understand that environmental hazards have been racialized. We know that the communities of color are most impacted. But I think as a field of scientists, I know at the NIH, we are thinking about them in a different way, thinking about them through the lens of structural racism, the impact of that racism on health. And then when you think about environment, thinking about the transgenerational legacy and trauma that has occurred because of the choices that were made of housing, of siting industrial places, of environmental pollution. And it's, like we said, multi-generational exposure. So the framework of the exposome is from conception through old age, but it's really of your grandmother or your great grandmother. That trauma really, moves forward in certain populations, especially those of color. We know that the segregated communities of color have very dirty and underregulated or unregulated industries. The housing stock is old and has a lot of deficits, few pollution controls, and few opportunities for monitoring those pollution controls, the level of pollution. The communities have poor nutrition, lack of access to food, and green space and areas for physical activity and areas of access to healthcare. So again, simultaneously, all of these things, the built environment, the environmental exposures, the social determinants of health are just piled up on top of each other. Next slide, please. And then this last year, we saw a really great publication bringing in the concepts of integrating intersectionality into the exposome. And although I had heard this discussed sort of at a high level over time, I think this paper really brought it all together for me, where when you think about the intersecting systems of oppression, of racism, of discrimination, of the lived experiences of people on the margins, you realize that environmental exposures are part of that intersectional experience, and that people who are most vulnerable perhaps biologically or medically, socially, environmentally. And the question is which one of these levers do you work on to improve the health of the person and improve the health of the community? I think we sometimes say that, if you can protect the most vulnerable in society, you can protect everyone. If you think about a universal design approach, if you're creating a safe walkway for the person who is going to fall and hurt themselves, you are providing a better walkway for everybody else. Or access for the person who is least likely now able to access something, you are improving access for even those who have had access over all these years. So I really like this concept, and it sort of helps me think about how we want to think about environmental exposures and the type of science that we do going forward. Next slide, please. So some of you may know that a couple of years ago, NIEHS created a translational research framework, which really looked at the kinds of research that we do over the lifetime of significant societal environmental health questions. And at NIEHS, I wish I had a pointer and access to the slides, but if you look at the purple in the middle, I think that's where we have spent most of our time, really working on the fundamental questions of risk, the fundamental questions of understanding the temporal nature, the timing of both exposure and disease outcome, and then quantifying those risks in a variety of populations. And then as you go out on the circles here to application and synthesis, implementation and adjustment, practice and impact, you're really moving along the trajectory of research to action to impact. And that's what I want to really put out there, that our work has really been on the documentation of risks, of health disparities, of environmental exposures. And I think if we want to stay in touch with how the rest of the fields of health disparities are moving and how NIH is seeing the world of health disparities and health equity, we need to move into this intervention phase and implementation of some of the ideas that we've recorded and documented over many years with outstanding publications. So I just want to put that out there. This is this sort of idea of how can we reframe all the great work we're doing and move it, push it through this translational trajectory so that we create new opportunities for collaboration and we see impacts in new and different ways. Next slide, please. So let's just define some important terms. I think, we're all really comfortable with a lot of the terminology related to environmental justice and environmental impacts, but these are the definitions that some of our colleagues at NIH have put forward for when they think about prevention research, intervention research, and implementation science. So prevention research is designed to produce results that are directly applicable to assessing and identifying the risks, but also developing and testing interventions to prevent or reduce the harmful exposures, disease onset, or disease prevention. And this comes from the Office of Disease Prevention, NIH, and their strategic plan. Intervention research, we all know about the traditional clinical trials and therapeutic interventions. The efficacy, we want to study the efficacy. Does the intervention work? Are we seeing differences in groups that get an intervention or don't get an intervention? And we know that this is super complicated in the world of environmental health because there are many things that the nature of how we are exposed, we can't intervene at a personal level, at a medical level, and we have been relying on policy-based interventions for over years to sort of have our intervention framework. And then the field of implementation science. Now that may be new to some of you. It was new to me over the last couple of years, but I see this as an opportunity. And what I want to show you today is examples of interventions that we know are out there. We know that they work. We have some understanding of a level of efficacy, but we also have a lot of research opportunities to go through the process of studying methods to promote the adoption and integration of these evidence-based practices, the interventions and the policies that impact on routine healthcare and the public health setting. So basically to improve the health and life of people in the communities that we care about. Next slide, please. So here's just a graphic of this public health continuum. So the lightest blue circles, that's where we've been, that's where we're comfortable. Now, incorporating community engagement was a new thing in environmental health, and NIEHS with Dr. Olden, past director's vision, we really pioneered that in these fields. And I think through our core center network, our P30s with our community engagement cores and through all of our other, what we call landmark programs, community engaged research and community engaged participatory activities is just really part of the fabric of environmental health now. We've done a lot of observational studies. We have a very nice, robust environmental epidemiology portfolio. We have really great science using community-based participatory methodologies. And I think in our observational work, we do identify intervention opportunities. And in some cases, we find mitigation strategies to use to apply them. And we do have examples of where this has been successful. So we've done a little bit of effectiveness research, but we feel frustrated. I feel frustrated. Maybe some of you feel frustrated that we have not really achieved that same recognition for some of the interventions. We don't even call them out that often as interventions. We're not using the same language that people in the field of intervention science are using. So, we're pushed to the side a little bit there. So I want to say that in the future, we really want to focus more on the medium blue and the darker blue. And I'm going to give you a whole bunch of examples of, I think, where we're already doing some of that and some ideas for how we might and think together about how we might elevate that and, move it down that trajectory in the future together. And then at the end, I'll show you that NIH is actually creating some funding announcement opportunities where basically I do not want my environmental health community left out. I want you to be able to see yourself as, competent applicants to apply for these things. We've worked hard with the NIH partners to make sure that there is the language about environment in these things, but I do think it will require some reimagining and recreating the kinds of work that we traditionally do to fit into these new frameworks. Next slide. So moving from documenting health disparities to action. So that, this is a theme that I've put on the table here for us to discuss today. We've created exposure reduction, mitigation, and remediation strategies using a variety of technologies, using educational programs. We've raised health literacy, and we're doing that. We're funding that, and you guys are doing a lot of it with your partners across different other areas of science and collaborating across the field of environmental health. We also have to think about, access to health promoting resources, services, and spaces. So how do we integrate the delivery of primary or mental health care services within our EJ communities? How do we think about what are the kinds of questions we want to ask in terms of interventions or uptake of these services to promote health, to promote resilience, and to create healthier environments for people who maybe don't have a lot of personal control over the environmental scenarios that they face every day. Introduction of health screening and making sure that environmental justice communities or communities that we know that have under burdens, to get access to and take advantage of health screenings, because we know that the chemicals they're exposed to do have cancer endpoints or cardiovascular endpoints. And so the practice of these health practices is critically important for them. How do we make sure that there's environmental monitoring, air, water, soil, all these things that, are available are being done either by communities themselves, in partnership, more likely, we hope, with government agencies. And then how do we say that all of this, the results and the data here get to be part of the medical record so that people can understand the lifelong effects, and the physicians can take some of that to heart in working with their patients, understanding the challenges. Creating green space, parks, trees, and trails. I'll give you a really nice example of a study that's planting trees in Louisville, Kentucky, and why I think that's a really awesome, positive intervention for health at multiple levels. And then, of course, food security, insecurity, the use of urban gardens, understanding the toxicologic aspects of the gardening process, access to supermarkets, food co-ops, other methodologies like that to promote health promoting resources within communities that have a lot on their plates, so to speak. Next slide. I also want to, put out on the table, we're talking about the infrastructure to address climate and disasters and how to be prepared, how to bring communities in to understand the processes of empowering people to promote health justice and keep that health equity lens on the table around climate issues. Prevention of issues with water systems and mold and things like that are examples under the climate and disaster umbrella. And then infrastructure and structural changes to promote clean and health safe housing and neighborhoods. So even just simple environmental things like access to clean water, trash pickup to reduce pests and odors, traffic control to reduce air pollution, making communities walkable. These are all interventions that, they're part of the toolbox that we can use to help work with our partners to improve the lives of people who live in the combination of some challenging social impacts as well as environmental impacts. Next slide. So I just want to go quickly through, so the Department of Health and Human Services has had an environmental justice strategy for quite a number of years. And NIEHS and other federal agencies have been, working on multi-federal task force to create this strategy. And if you read this document, you'd read it today and you'd say it's relevant as today as much as it was in 2012. And you might also ask yourself, well, what have we done to change the landscape here so that we're not in the same space we were in 2012? And some of these ideas of promoting different kind of research might help us get there. So the goals of this strategy were to improve access to and quality care and services for minority and low income groups, tribes that have known disproportionate high levels of environmental exposures, and to advance the economic potential and social well-being of these groups. Those are great goals, and they apply in an unbelievable way to the communities that we have worked with, continuously for 20 years or more. It doesn't call out specifically remediation and reduction of exposures in the way that we have think about it, but it provides a bigger framework for us to think about how the interaction of some of these other intervening effects can also improve the environmental burdens that the people have. So next slide, we'll have some examples of strategies that were proposed then that I think are as relevant today as they were back then. So again, I mentioned training healthcare professionals so that they're more aware of environmental hazards and environmental justice. Making sure there's data in our electronic medical records and part of the encounters in our medical care system, impacts in the natural, the built and social environments, building capacity and attention to behavioral health, specifically related to trauma. And that trauma could be multi-generational systematic racism, as much as it could be the trauma of an impending disaster or one that's, a weather event that's already come through a community and has caused, havoc to the lives of the people who live there. Figuring out, again, this access to health services, to human capital services, to safety net services for the communities that have these impacts. And then medical services like health screening and health behavioral health services to make sure that we're not focusing only on early markers of physical disease, but we're also looking at mental health impacts and building resiliency. Next slide. So I'm going to go through 3 buckets of research that I consider to be things that we are already doing or things that we could do or new ways to think about older problems. The first is the sort of recognition of natural experiments. And I think right now, because we're in COVID and we've seen so many things in our lives change, the natural experiments are relevant kind of study design to see what happens when life returns to another time, or collecting data during this time of staying at home, reduced traffic and commuting, and reducing air pollution burdens is a good example there. Interventions. So, I want to be clear. I don't ever want us to think that we're going to move away from reducing the primary hazardous exposures. I'm not here to sell you something else in place of that. But I think that only thinking about those and not thinking about these other ways that we can intervene in concert with understanding the environmental exposures that communities face will be a new way to think. So behavior change, whether that be individual personal behavior change or local government behavior change or institutional behavior change, understanding the systems of behavior and the systems of governance and regulation is critically important to our, implementing interventions appropriately. Improving environmental health literacy, awareness of so many of the stakeholder groups. We've seen enormous power be brought to communities when we raise environmental health literacy through academic and community partners. Your center is, right at the forefront of that, and I applaud you for all that great work that you've done, in your center for probably 20 years or more. Positive improvements, right? Let's not just look at the negative aspects of communities. Let's try to build positive improvements to our built environment and to our community structure and supports, and providing healthcare, health promotion, and safety nets to communities, specifically the ones that we know are struggling with environmental exposures, are really important interventions to think about as well. And I don't think we've done as much work in those sort of the last 2 bullets there that we have in the other bullets that we've talked about. And then the new field of implementation science research. And this is once you have an intervention that you have some level of efficacy for, you can then start to think about how you adopt that intervention, what the uptake of that intervention is, how sustainable it is, the reach and scale, and then how to build, how to introduce technology, behavior change, and policy into communities, and then look at both the social effects, the environmental effects, the economic effects, and the changes in population health as it relates to those interventions. Next slide. So first we'll start with natural experiments. You'll see at the top of the slide in different colors, I've identified it with the bucket that it sits in. Some of you may remember back in the early days of the Children's Environmental Health Centers, our Columbia Center had the opportunity, they had a birth cohort where babies were being born at different times. And during the early days of their study, the US EPA banned the residential use of insecticides containing chlorpyrifos and diazinon. And so before the ban occurred, they were able to study the impacts of those chemicals on birth outcomes. And then after the ban, they were able to, for the next cohort, they were able to study the levels in that next cohort of babies that were born after the ban. Mothers were pregnant after the ban, and they were able to measure reduced indoor air levels of these chemicals, and they also were able to show lower bio levels in the cord blood in these placenta from the births. So next. Right now, this group in Columbia has turned their attention to during the COVID shutdown and sustained air pollution quality. And they've asked the question of, well, what happens if we were able to sustain a reduced air pollution level like we've seen during COVID-19 and predict out what kinds of modeling can we do to see the cumulative health and economic benefits? So using predictive modeling, using economic models as part of this world of intervention and prevention research, I think is important to be able to make the case that we can improve the lives of people by reducing exposures, but also looking at social determinants as these change with.
Did you want me to send you this anti-inflammatory bioactivities and plant extracts paper?
Whoops, I
Is
think
that from you?
Need to go on mute. All right, well, I'm hopefully not talking over him. Anyway, so in order to be able to predict the future, we can use this natural experiment time that we have now to try to figure out what kinds of models we want to build to enhance our prevention intervention research. Next slide, please. And the third one that I want to use as an example is the co-benefits of climate change mitigation. So when we see energy transition occurring, closing of coal and oil power plants in California, we're going to see we hope we'll see dramatic changes in the energy sector, in the introduction of electric cars, in the transportation models, in our use of petroleum products. These will be natural experiments that will occur over time. And so Joan Casey and her collaborators were able to demonstrate that there were reductions in preterm birth, there were exposure levels that were reduced, and they could see reductions at the zip code level for things like asthma-related disease burden, and then the clinical implications of having a healthier life because of the reduced exposures, reduced medical utilization, reduced medication utilization. I think these are all really fascinating endpoints to consider within the context of these natural experiments, and they make the case for prevention being possible and intervention being possible without actually having to design the interventions ourselves. We just take advantage of things that are occurring in our moving environmental space. Next slide, please. So now I want to move to interventions. The blue indicator on the top show the next several ones about interventions that are occurring, studies that have been well done and well received. And the first one is in Washington, the state of Washington. It's called the HAPPY trial. It's related to indoor air pollution and the use of HEPA filters and asthma education to both reduce exposures to PM 2.5 and ammonia, and to look at the ability to reduce the asthma health metrics, increase the control, reduce exacerbations, improve lung function. And this work was done in an agricultural community, a Latino population, using community engaged research, participatory partnerships. And with using rigorous designs, they were able to show that the HEPA filter reduced the levels in the child's bedroom by 60% and in the living room by 40% compared to education alone. Next slide. Nutritional education approaches, educating the community about healthy fruits and vegetables that might have protective effects and be related to reducing PCB exposure. This was within the context of a Superfund center that was looking at how PCB exposure impacted their local area and showing the relationship between PCBs and cardiometabolic outcomes. And they focused on the nutritional interventions that could be done to improve both overall health, reduce PCB exposure, and then, hopefully with the longer term goal of increasing cardiometabolic function, in the participants. So teaching new cooking methods, voucher program for buying healthy vegetables at the farmer's market, teaching classes about the role of the polyphenols in the fruits and vegetables were all very powerful ways to intervene in the community, and they were able to see positive behavior change. Next slide. This is a really interesting study. I think I like to call it an intervention. This was done through our research to action, and we didn't have a requirement in that program for sort of a true intervention, at the gold standard randomized control trial level. But the kinds of techniques that this community academic partnership in Sunset Park in New York, with the community group Uprose, chose to implement, I think is definitely could be considered an intervention. So what they were looking at was in areas that were affected by Superstorm Sandy. They had a community that was on the Gowanus Canal. They had damaged homes and businesses where there were chemical releases into those areas. And the community is very concerned about the warehousing of chemicals in this area. And so they chose to address the health risks associated with these chemicals by implementing risk assessment frameworks and doing assessments, building the capacity in the small businesses to develop their own assessment techniques, for them to learn how to be prepared to contain the chemicals during a disaster scenario. And, hopefully they'll never have to employ these if the effects of climate change don't hit this area again. But if they do, they would have an evidence-based approach that they could have confidence in, would help them, not be impacted in the way as if they were not prepared. So I love this because, it's an innovative kind of intervention in thinking about it. There could be rigorous types of methodology used to test whether they work. And then there can be implementation science to make sure that businesses take this up and it becomes part of the local and more regional. It could be implemented in lots of different places that might be under risk for chemical releases associated with climate change. So I thought that was super creative. Next slide, please. So I mentioned before, I wanted to talk about a positive intervention that was happening in Kentucky, Louisville, Kentucky. And some of you may know about this study. It's gotten a lot of press. It has a very impressive website. There's been NPR coverage of this work. And we have a NIEHS PH podcast that Dr. Bhatnagar recorded for us. And I would recommend that you listen to it if you're interested in this. So if we think about urban spaces and we think about the toxic legacy of redlining and other systematic racism, communities of color in urban areas don't have the green space that other affluent communities have. They have heat islands. They are hotter in terms of heat because they don't have the ground cover, because they don't have the trees. And oftentimes air pollution is worse in those areas. And so the health effects in the population are related to unhealthy air, but also related to the potential impacts of climate change, and make those spaces more risky for people, especially those who are most vulnerable. So they've taken on, with the Sierra Club, I believe, locally, planting about 10,000 mature trees and shrubs throughout these communities. And they're using a community design. So there is a rigorous statistical methodology that can be applied to see over time if these improve air quality, temperature, mental health, social cohesion, and cardiovascular risk. We at NIEHS are funding the air pollution, air quality health assessments, and the Nature Conservancy in Kentucky is supporting the planting of these trees. So no matter what the outcome of this study is, the built environment in these communities will be enhanced. And, you know, that goes a long way. That goes a long way in appreciating the legacy of racism, in improving the quality of life in these communities, in making it just a more pleasant, nature-based space where children can grow and develop. And I think there'll be really positive mental health outcomes from this, and they'll be able to test it with their design. Next slide. The next two slides are more health access type interventions. You know, again, health disparities communities have lack of access to a lot of services that more affluent communities have. And here's an intervention where they've created health action centers that allow these communities to, these are communities that are identified as having a high burden of premature mortality. And they're co-locating clinical services with community partners, referral systems, social work, nursing services, pop-up clinics for not only medical services, but legal services, and then providing, you know, a nice healthy space for convening and hosting community events. So I think about this, well, if this is an appropriate venue for delivering those kind of services, maybe there's ways to engage communities around the conversation about environmental impacts in these communities, and then work through these structures to implement environmental health interventions and build the connections between the environmental interventions and these other health system interventions. I don't know of any studies like this right now. I sort of did a quick look at the literature while I was preparing this talk, but I think this is really a future opportunity to think about how those partnerships and leveraging other work that's already been done offer a level of entree for the environmental health community to become partners in working together. Next slide. Okay, now I'm going to move on to implementation science research. So some of you are familiar with the intervention trials that are happening around the world related to reducing biomass burning by using cook stoves that get away from biomass, replaced by LPG gas or natural gas or other methodologies. NIH took on a big effort across 4 different countries, Guatemala, India, Peru, Rwanda, about 4 years ago. We call it the HAPPENS trial, Household Air Pollution Intervention Network Study. And in addition to just testing the intervention, there's a whole implementation science network built around this study where we are measuring and testing whether the community is adopting these methodologies, learning what the barriers are, what the challenges are, trying to understand if these things can be scaled up. Some of them, in India in particular, the intervention work is looking at how India is implementing a countrywide policy on LPG gas for stoves, and you know, whether the policy change is helping us achieve our health goals or what the barriers might be. And so there's a policy implementation component to this implementation network as well. So these are situations where these things are working hand in hand and being studied around the same times. Next slide. The Strong Heart Water Study. So you may be familiar with the Strong Heart Study, which has been on North and South Dakota American Indian communities. It started as a heart study, understanding risk factors for heart disease in these Indian populations. And then our environmental investigators knew that there was arsenic on these lands and that the communities were concerned about these. So they started randomized controlled trial studies to reduce the arsenic. But we have a lot of international experience with reducing arsenic. So we know we can do that. We know we can reduce it in the water. We know we can reduce body burden in people who change their water source. In this study, they were in the context of rolling out this trial in a population where this hadn't been done before. They brought together a community workshop to talk through all of the stages of the implementation of this trial to try to really get formative research work on developing an educational program, a point of view system, understanding the technology, the delivery, understanding how the community wanted the information communicated, how what the importance of the cultural competencies, and how critical is that, right? If we know something works from a technological standpoint, we don't necessarily know that a community that we bring this to, even if we're in partnership with them, will fully adopt it, and we will be able to really see the maximal impact of our intervention. So the field of implementation science will help us get there and understand those factors. Then you can change the delivery. You can change the way you communicate. You can change and provide support so that there can be maximal adoption and reach for the interventions. Next slide. And then this last one I put under implementation science. I don't know that Silent Spring would characterize their work necessarily as implementation science. I think, you know, they have been pioneers in developing these readback and feedback reports. You know, they're so much more prevalent in our work now. So I would say it was an intervention, right? To give results back to people and see what the impacts were and how it impacted people's understanding of their exposures. And I think there's a lot of evidence to show that that's been a successful intervention. So now what do we do next? How do we make sure that all studies involve a report back? The Brody group has developed a web-based interface. They've developed critical ways to visualize the data and communication techniques and working strategies to work with communities, which I think is really part of the implementation of this kind of method into the adoption of both the field as well as any individual study. So that's why I put it under the implementation framework. Next slide. So I'm just going to quickly go through implementation science. I don't know how much you guys know about this. It's fascinating. I would encourage you to read more about it. But implementation science is the study of the methods to promote the adoption and integration of evidence-based practices, interventions, and policies into our healthcare and public health settings, because we want to improve, you know, our ability to impact population health in a positive way. Next slide. It's sometimes confusing because you're talking about intervention and then you're talking about implementation. So the intervention is the thing, right? It's the thing you're changing. And so the intervention and the practice, they call it the thing. This publication makes it sort of simple to understand. The effectiveness research that is aligned with the clinical trial or the other methodologies is looking whether that thing works, right? The technology, the change, does it work? Implementation science looks at how to best help people actually do the intervention, actually accept the intervention, actually understand the intervention and its importance on whatever, you know, the scenario in which you're introducing it. It's the stuff we do to have people understand why the interventions are important, not just from a research point of view, but also for, you know, sustainability and implementation over their lifespan, if that's appropriate. So I really like this framework, and I recommend this publication to sort of use this terminology as a teaching tool. Next slide. So, you know, if you don't think that there are any strategies, well, there are at least 73, because this group came together to compile a lot of different strategies in the implementation strategy space. Next slide. And so they used a Delphi kind of approach to, you know, pull together a lot of implementation strategies and have a community of people prioritize them. And I looked through all 73 and, you know, I was pretty impressed. A lot of what's in that list we have already included in our environmental health science research practice. Now, a lot of what's in that list is specific to clinical implementation of interventions. And okay, maybe, you know, I hope after this talk, might think about working in that space too, and you'll have some understanding of how to, you know, adopt those practices. But I think a lot of these strategies cover both areas. And since I think they all, you know, really line up on top of each other. They're all strategies that make sense in what we're trying to do from a environmental public health standpoint. Next slide. So if you think about implementation outcomes, right? So you're going to have these strategies, you're going to change stuff. And then what is it you want to see in your studies? Well, you want to see whether your intervention is taken up by the community and at what rate, and who in the community takes it up and who doesn't, the appropriateness. So just because we've got a great technology doesn't mean it fits the community that you're working with. And you can learn that pretty quickly with an implementation science. The concept of fidelity, that was new to me recently. That means that the way you're supposed to implement the technology sometimes has to be modified. And so is there a change in fidelity? That doesn't mean that you have to do a whole new intervention study to see if that different strategy is how you're supposed to implement it. It's part of the content of the implementation science outcomes. Cost, penetration within a community, the acceptability, whether people use it, is it feasible? You know, sometimes we create constructs that are complicated, they have a lot of burden. Are they acceptable? And then of course, are they sustainable? Do people want to change their behavior? You know, do systems want to change? Are we able to sustain that change in the system? What else is necessary to sustain this? And this is sometimes where the policy, you know, outcomes also can become part of the implementation science. Next slide. So, you know, we need to be rigorous. So we have methodologies, and there are, you know, quite a number of publications. I'm not going to go into all these study designs, but just, I think the point I want to make here is you don't have to do these things as separate activities. You could have a sense that, and you have enough evidence that an intervention is worth studying, or you're in the process of this, well, you can add implementation activities to your trial at the same time. So there's hybrid ways to bring both the effectiveness research and the implementation research together so that we're not slowed down and that we don't miss opportunities to understand all those critical factors when we're in the field, you know, using that precious time that we have with the study subjects. Next slide. There's also theories and models and frameworks related to the implementation science process. These are 3 different frameworks and ways to think about things. Again, I can make these slides available. You can go to these websites. I'm not an expert in any of those, and I'm just learning as well. NIEHS is going to have a workshop with some other NIH partners, I think in early 2022, so January, February timeframe, on implementation science for environmental health sciences. So hopefully I've sparked your interest in this and you will participate in our virtual meeting and learn more and bring your examples to that workshop so we can share already what we're doing in this space. Because I think maybe we're doing some of it and we're probably doing a lot of it, but we're not calling it this. And that's an important issue because the rest of NIH is calling for these kinds of research to be put under these rubrics. And so, you know, vocabulary sometimes is important. Next slide. So with all of these things, we have to remember the ethical, legal, and, you know, social implications of this work. While I was thinking about all these interventions, the thing that kept flying in my head was back in the 1990s, the Baltimore lead paint study that was conducted by Kennedy Krieger that was, you know, had to stop in the middle because there were allegations and, you know, obviously imperfections in their research design, and communities of color were harmed by the interventions or the withholding of interventions to people that needed it and were most vulnerable. So it really goes back to that framework of intersectionality. If you think about those oppressions, if you think about the historical framing of the racism, of the environmental injustices that our communities have faced, we better really understand the ethical, legal, and social implications of all of our work in order to, you know, make sure we can do the best for these communities and certainly not do any harm. Next slide. So we have best practices in our current work every day. The things on this slide are not new to you, so I'm not going to go to them in great detail. The next slide, I think, is really what I want to focus on. That what are our new best practices? So some of our new best practices are to think about intervening when we're thinking about the risks that our communities face. What do we want to intervene on? How do we want to create the interventions? How do we want to put the framework together so that the community is in with us right at the beginning and understands the value of seeing these change. I believe these communities are really asking for that. Certainly the field of health disparities defines themselves as a field of action, not just documenting, past or current levels of oppression or differences. It's really how do you move from that into fixing those problems and creating a solutions-based approach here. We want to test and understand the ways to improve, adopt, and scale these. We have to incorporate social determinants of health at everything we do. It's not one or the other. It's not one scale of questions and then another scale of inputs. It's how do these exposures distribute along these social determinants of health, and how do these social determinants of health impact the exposure distribution? I've mentioned these other things. Focus on these health disparities factors. Get into that lingo, into that mindset. How do we make sure that our environmental justice work is part and parcel in the framework of the broadest sense of health disparities research, and that we are never left out of the world that the health disparities researchers want to create, because they can't be fully successful if they're not considering the environmental contributors to the diseases and the problems that they're talking about. We want to incorporate these interventions in ongoing health trials or other intervention opportunities, creating collaborations with the clinical world of people who are doing trials. Where can we sit at the table with them and discuss how we can bring our expertise to the table? And take advantage of these natural experiments, because there's going to be a lot of them. Right now, we're living one in the current years. If we're talking about the climate change crisis and all of the policies and things that the Biden administration may bring, to fruition, there's lots of opportunity to have a research foundation as part of that, so we can document and provide the evidence for those policy changes. Next slide. Okay, I'm almost done. The last few slides here are all about new funding opportunities. And this is really what got me thinking about this. So this funding announcement was developed by the National Institute of Minority Health and Health Disparities, and it started to be created last year after the George Floyd murders and the conversation at NIH about how systemic and structural racism is a public health crisis. And so it was a great opportunity. Everybody was thinking about it. What did you have in your portfolio about health disparities, about environmental justice, about racism? And then when we saw the framework of this, it didn't speak to me. It didn't say, implement studies in our environmental justice communities that study these things. But everything we know to be true in our environmental justice communities, a lot of it is about the toxic legacy, multi-generational policies and impacts of environmental health decisions, or environmental decisions that have led to health problems. So we joined on to this, like many other institutes, and we were able to put language in here to make sure that our people can show up and apply, and that your work should be valued in this content as well. So here you'll be able to do observational studies, which will be great, and we know how to do that. But I want to push you to think about going farther than that, and to think about the intervention strategies and the partnerships that you can build so that you move the dial to the action part. So you got some time to work on this. The letters of intent are due in July, and the funding announcement closes in August. And Lindsay Martin, who is our medical anthropologist in our division and our implementation science guru, is happy to talk to any of you who are interested in putting in an application here. And then, of course, you could always reach out to me as well, and I'll put you in touch with the right people. Next slide. So then you might have heard that the NIH has been really working hard over the last 6 months on an initiative that's called End Structural Racism. And it's all about the culture and climate within NIH and the systemic racism that we see in our own workplaces, at our own institutes, as well as how these things impact the extramural community, research infrastructure, and ecosystem. And a piece of this program is about health disparities research. So NIH wants to lift up health disparities and health equity research. We're all in favor of that. We've been doing this. We'd like to see more funding for this. And so they put together a common fund initiative, which comes from a fund of money from the Institute leadership, the Office of the Director, for 2 transformative research initiatives addressing head-on health disparities, health equity, and then both at majority universities as well as minority serving institutions. They're looking for innovative intervention and strategies that address these health disparities. And, you know, if it doesn't sing to you in terms of environment, I'm telling you, I'm here to tell you today, you can apply to this program. I would love to see as many applications as possible so everybody understands that this is part of what we do and this is part of the health disparities work. There's some points of contact, you know, if you have questions within the funding announcement, and I really encourage you to think about doing this. The applications are due, so hopefully you've already started and you already knew about this before I started talking about it. But it was fast track because they really wanted this program to come out. I think there'll probably be more funding for this in the future. So even if you are not able to meet this deadline, it's good to start thinking about this kind of framework. Next. And the last one is a standing program announcement that we've been working with NCI on for a number of different years. 3 different research opportunity mechanisms to, you know, put in applications related to the implement science things that I was discussing today, and the things that you've already been doing, maybe using new terminology, maybe using a different framework, maybe bringing in consultants or collaborators who, you know, have direct experience in sort of the traditional thinking and implementation science. But, you know, like I said, we're going to have a workshop because we think that environmental health fits in this space, and we think that these tools and methodologies bring a lot to our discipline. Next. All right, well, I just want to thank my colleagues. You know, I couldn't conceive of this talk and conceptualize it by myself. Liam, who many of you know, Lindsay, who hopefully some of you will get to know, and Claudia, who you all know, helped me think through this and talk through it. And then my colleagues at MDB Associates for helping me make the slides today. And thank you all for your attention. I would love to have a conversation with you about all of these concepts and what you think of what I just said.
Well, thank you, Gwen. A lot of issues here to open up for discussion. So I'd like to open up the floor for any discussion, perhaps possibly either by raising hands or waving wildly, so that I can see that you do have a question to sort of keep it under some organization. So would anybody like to start the discussion? As they develop their questions, I guess I have a question for you.
Sure.
And so that is, you know, I guess one thing I hadn't appreciated, I mean, it clearly, you know, and maybe this isn't, I don't know if it's a comment or a question, but, you know, clearly this to me is, you know, a strong emphasis on intervention and implementation sciences that maybe I hadn't fully appreciated from the Institute previously. And so is this a pivot? Is this just, I mean,
you weren't snoozing, you didn't miss anything. But I would say that, you know, under Dr. Birnbaum's leadership, when we created our first strategic plan, we did have elements in our strategic plan that focused on prevention and intervention. And I think we framed it in our traditional way of, you know, lifting up environmental public health, using the community-based strategies to do our work in a framework that we were all comfortable with. So that topic continued in the second strategic plan, and it's in the translational part of our framework. But when I think about it, there's research-based work, there's evidence-based practice, there are rigorous research methodologies that we can use to, I don't know, is legitimize the right word, or to have our work be seen on the same level as other intervention studies. You know, I don't know that all the work we do is adopted as broadly as we would like to see within the health disparities community. I would tell you that I'm in many, many conversations where environment doesn't come up in the conversation of social determinants of health or in health disparities or health equity. And I think, you know, we'll see less of that as we move forward with the intersection of climate and health equity. But, you know, I want us all to be at the table together. I think we have a lot to bring to that conversation. And it's a pivot in thinking. And I think we can push ourselves along to maybe do some little different science that will have maybe a stronger translational impact.
No, I think it's a great step forward. So thank you. Yoshi, do you have a question?
I do. Thank you so much for your talk. I really appreciated all the scope you covered. I actually want to kind of have a little discussion when you talked about, do these communities want to change in terms of how we think about implementation science? And I guess I would say, looking at academia, and this is more like academic space, like do academic institutions want to change? And especially this year, I think we've seen some academic institutions making strides towards that and who they are hiring, on who they are inviting to speak, on whose work they are promoting. But it's very minimal still. And when we find in these types of spaces, either workshops, conferences, seminar talks, you still see it's very, you just see it on who attends and the conversations we're having. So particularly with your call that you had with the RFA on structural racism and now the Unite initiative, do you actually think, or on these conversations in academic spaces, how do you actually think there are going to change, or what, I guess harder steps do academics need to be pushed on to say, hey, like, get your stuff together? Because, I don't want to be sitting here 10 years from now, if I do become an academic, having these conversations over again. And it's very, I definitely appreciate you opening up the conversation for this.
Yeah, thank you. And thank you for putting it in that framework. I mean, I've been part of the establishment, right? In my roles of leadership. I have thought a lot about this in the last year, and, we did some things, but we didn't necessarily do enough. And we supported a lot of things. Our institute, we're one of the first to encourage community-based organizations to apply for grants at NIH. And that was hard. That was hard for everybody. And then, we pivoted away from that. And then we gave that power and control back to the universities to bring in these partners and then make decisions about how funding occurs for our community partners. Could we have done more to make more explicit rules, to make sure there was equity? I mean, we acknowledge the need for equity. We listen to people say. I have heard it, many times. Did I, as the director of the Institute extramural program, do enough? I don't think so. But I see it differently now. And I hope that in that next phase, we will do the things that maybe we were afraid to do before, right? And it requires everybody to work together. If you haven't read the NIH Ending Structural Racism Initiative on the website, it's the most powerful stuff I've seen in my career, where people are taking responsibility and listening to people who haven't had a voice in a long time. It's not going to be fixed tomorrow, but at least there is a willingness to engage and to work on this. So I believe that, our next generation will pull us in those directions and will keep us accountable and won't let us, let it slide back. So I feel very hopeful, and I'm inspired by all the voices that I hear and people speaking very honestly about what their lived experiences have been, it was a huge disconnect for me. I was walking in communities with you guys and others, listening to what people were saying. And then I was going back in my office and I was just thinking about things in my old traditional way. So I need to personally stop doing that. And I need to appreciate this more. And I think the people at NIEHS are willing to think all that stuff through.
Other questions? Yeah, Rima.
Thanks so much, Gwen. I mean, I think we all appreciate how much you see and listen, and we know you really care. So I guess one thing that struck me with this, and I agree that, it's not coming out of the blue. I mean, we've heard these concepts have been around. We've seen them in a lot of kind of RFAs before. I guess what struck me now as you're talking about this is that it's like, to me, at least, if I do a lot of observational research, clinical trials kind of scare me a little bit because they feel like they come with added responsibility to kind of expose people to things or tell them what to do. And so how do you see us kind of, groups of researchers who've been used to observational research kind of take that step forward and jump into more of an intervention clinical trial mindset and not be intimidated by that steep learning curve, in terms of what comes with that?
Right. I totally appreciate that question. And recently we were thinking about how to bring a wider, breadth of methodologies and study designs to the acknowledge, so the community knows about it, right? Like, I'm sure there's some siloed coursework across the university. And if you're not going to be in drug development, you're not going to take the classes to do, the gold standard clinical trials. But, so the Office of Disease Prevention at NIH has just been talking about this for a long time. There are so many different study designs. Now, I recently worked on this RADx Up program that some of you might be familiar with. It's about testing for the virus and then, getting the testing scaled up. And that was, to me, I learned about all of these new methodologies. So, we're smart people. We know how to do complicated studies. We can learn about new methods and apply them, but nobody has sort of packaged them up and delivered them to us, right? So I thought, well, maybe like at ISCE or in some other, society venues, we could have a workshop. So in this implementation workshop that's going to happen next year, there will be some of that, but I think there will also be a need for a deeper dive. So people truly understand the study designs and the methods and how to think about these questions in the context of the not so scary gold standard randomized controlled trial, because that's not what we're really saying you all have to do. We know that we can't do that for so many of the exposures that we have. We might be able to do that for some of these other factors, that are explicitly linked to those exposures. And who knows, we may find if we improve neighborhood environment or we improve, another component of a person's ecosystem, maybe their body burden will change. Maybe their actual exposure will be reduced. We just don't know that. Nobody's looked at it from that standpoint.
Other questions? Yeah, Rob.
Yeah, I'd just comment to all the folks from USC. We recently put in an application for one of these Children's Environmental Health Research Translation Centers, which are supposed to be about implementation science. And after looking and looking and looking, we discovered that Tom Valente in our department is a world expert in implementation science. So if you're thinking about responding to any of these RFAs, you should talk to Tom.
Other questions or comments for our speaker? Well, I don't see any hands being raised. So I want to thank you all for attending the seminar today. I want to remind you again that next month's seminar will be by Bruce Brunegrief, talking at the John Peters lecture. And you'll be seeing a flyer and announcement for that, but put that on your calendar for June 4th. I want to thank Gwen Coleman for taking the time to meet with us today and make her presentation. We're going to take a short break, Gwen, and then resume with smaller group meetings into the afternoon, and I guess with the time difference into your evening possibly.
So no problem. I'm happy to stick around. And, before we sign off, there's so many names here of people that I wish I could walk over and shake your hand and say hello. And Leslie just texted, chatted here. Leslie was somebody I wanted to say hello to. And, there's just no good way to have this little social chit chat. But, I'm looking to see who's here and, and all the new people. I wish, that there was a way I could get to know you. But, I would say reach out. I'm very accessible. I'd love to have follow-up, chats if we're not in meetings together today. If something I said today rubbed you the wrong way, you don't agree, let me know. I mean, I'm putting my thoughts out there, right? These are frameworks that we can develop together. And I have always benefited from the wisdom and experience of the faculty and trainees at USC. So let's just continue the conversation, even if we have to do it over email or subsequent Zooms past today. And thanks for having me.
Thank you. And thank you all for attending. We'll see you next month.